have a lot of feelings about what rest settings are.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C. Zach, what are we talking about today?
So today we have part 2 of our phenomenal outline of the entire VV ECMO course with Dr. Jenna Miller and Dr. John Daniel. We covered the entire VV ECMO course, from cannula type and positioning to even more complex protocols like the decision to extubate and how to get your patients to the point where they can walk around even while they're still on the pump.
Yes, we are so lucky to have recruited 2 experts for this series. Dr. Jenna Miller is a pediatric intensivist and Dr. John Daniel is a neonatologist. They can really speak to the full age spectrum.
Dr. Jenna Miller is an Associate Professor of Pediatrics at the University of Missouri-Kansas City School of Medicine. He is the Director of the Pediatric ECMO Program and the Pediatric Critical Care Medicine Fellowship at Children's Mercy Kansas City.
Yes, and Dr. John Daniel is an Associate Professor of Pediatrics at the University of Missouri-Kansas City School of Medicine. He is a practicing neonatal cardiac intensivist, and he is the director of the Neonatal ECMO program at Children's Mercy Kansas City.
That's right. Let's jump right into part 2.
So let's give you a case update.
Okay.
The newborn infant with meconium aspiration and refractory hypoxemic respiratory failure has continued to worsen despite optimal medical therapy. You decide that she should be cannulated on to VV ECMO. After you stabilize your neonate on VV ECMO, you're called to the bedside of the 16-year-old with severe ARDS. He's developed a pneumothorax, and he has persistent hypoxemia despite high ventilator pressures and FiO2. You also decide to cannulate him onto VV ECMO.
What kind of conversation do you have with your surgeon and your ECMO technicians about where to cannulate, what size cannulas to use? What's on the table for us today?
So most commonly, our pediatric and neonatal patients are going to be cannulated through their right internal jugular vein, and we usually use a dual lumen bicable cannula. Most commonly in recent history, that has been the Avalon. We have not actually had that cannula in small sizes, as John talked about earlier, but we have had it available for our bigger patients and certainly for our adolescents. The first thing you want to think about when you're selecting a cannula for VV ECMO is the size of your patient. And so each cannula comes with charts for the size of your patient and your desired flow characteristics, and you can start there. If your patient is not of ideal body weight, meaning overweight or underweight, you may have to do a little bit more measuring to make sure the length of your cannula is where you want it to be. So you have to think about what is an ideal body weight for this patient, and then think about what type of flow you want. I'll talk about flow a little bit later, which can be a bit more necessary to push flows in VA ECMO. But in VV, we often have less need to push the flows up higher. And so we think about generally the age and the flow needs when we're thinking about size of cannula. While single-site bicable cannulas are most common, there is some literature about multi-site VV, and that is possible even in neonates in one paper that was published pretty recently. But it is less common and it is trickier, and so certainly if you have lesser experience with this, it's going to be more of a challenge, especially if the patient needs a longer ECMO run. And here I'll just mention that while we're talking about VV as the go-to for respiratory failure, if you look at ELSO, 65% of runs are VV. So that means actually a third of respiratory runs are still done via VA cannulation configuration for various reasons. Now to what you need to place these cannulas. So some of that is surgeon dependent and institution dependent. However, you're going to need echo guidance for this because these cannulas have termination in the IVC, and so we want to see that the cannula is actually in the IVC. And also we need to see that the reinfusion port is oriented towards the tricuspid valve, and that is critical. So we need to make sure that that highly oxygenated flow of blood is going straight towards the tricuspid valve, right into the right ventricle, through the lungs, and then back to the left side and out into the systemic circulation. So if that jet isn't oriented correctly, then it's going to be pointing up or down or sideways in the right atrium, and the blood is going to mix. And so you're going to have more venous admixture, and the patient's going to be more desaturated. So it's really important for that reinfusion port to be oriented correctly. Some institutions will also use fluoro guidance, so we do that. We use fluoroscopy for our placement because that wire has to come down through the IJ, through the right atrium and down into the IVC. And so in order to try to avoid injuries, we use fluoro. Not everybody uses fluoro, especially for centers that have long history with these types of cannulas, but we do. And so that is used for the placement of the cannula, and then we use echo to make sure that the jet is oriented correctly.
So you'll bring like the full fluoro arm in like it's an ortho procedure into your PICU room?
So in our institution, we actually take the VV Avalon cannula patients to the OR so that they can use the fluoro. So that's a whole process. Obviously, again, we have to do it at the right time so that they're stable enough to get over to the OR. When we do crescents, which we just do by echo guidance, we do those in the room.
Interesting.
Mm-hmm. We have brought fluoro into the room for a COVID patient before, so we were able to get that up there, but it doesn't fit in every room. So again, if you're in a room where the fluoro can't fit in there, you have to move anyways to get fluoro up there. So we will do those patients in the OR. But that is very institution dependent, and whatever the process that your institution develops with the cannulation team is probably the right thing for your institution. That's just how we do it.
Oh, thank you.
I have a couple quick follow-up questions. So I just can't imagine walking down a VV ECMO candidate to the OR. I'm sure you guys have a great system, and I want to learn more about that. Do you have like a formal handover to anesthesia, and then you just turn the patient loose, or is this like everyone walking down together?
So we have a standard work document that we have for our respiratory therapists because, as we discussed, these patients are often on high ventilator settings or an oscillator. Nitric is common, so you have a lot of equipment. So we have a standard work document that helps us determine what type of gas flow and power sources we need in the OR to bring all of these things into the OR. And then, as I talk about later, transitioning potentially to a conventional ventilator if I'm not on a conventional ventilator. So we have a lot of equipment that we take back there. So there's standard work that the respiratory therapists follow to ensure that we've got enough equipment, enough power, and enough gas to be able to supply all of those things. As far as anesthesia and the ICU physician, we absolutely do a handoff up front to say these are the things that are going on as far as settings, if there's any inotropes, access, all the important things that the anesthesiologist is going to need to know. But generally speaking, we also will go back to the OR. So if it's in the middle of the night and I'm the only one available, then I may not be back there for the whole case, but I absolutely, and our team in general, will be back there when we get onto pump, so that we can help manage any tweaks that the pump needs, and then as well as change the ventilator settings, which I'll talk a little bit about later.
Thank you. How do you think for neonates specifically, how do you change the way you're thinking about your cannula size and position?
So cannula size and position is the bane of a neonatologist's existence. We don't have a lot of real estate like our friends in the PICU. If you've ever seen an adult cannulated for VV ECMO, it's impressive. I mean, it's a garden hose that goes in their neck. I think particularly with VV ECMO, the biggest thing that we've learned is cannula position is so crucial. When the Origin cannula was on the market, and that was the primary one that was being used, it was very positional. You really had to have that reinfusion port shooting straight at that tricuspid valve in order to get oxygenation going, to get blood flowing in the right spot. The advent of the bicaval cannulas, I think the Avalon cannula that came out was a fabulous cannula. The bicaval design was beautiful. Very little recirculation, very little problems with it, I think, in older patients because you had more real estate. When you have centimeters versus millimeters of area to move in your SVC and IVC, it's a little easier, and when a little tiny millimeter is not going to cause a big issue. And so that's the biggest problem with the bicaval cannulas in neonates. Similarly, with the new cannula, the Origin went off the market, I want to say in 2017, 2018, something like that. So we just got kind of that new dual lumen, non-bicaval cannula that Crescent came out with. And we've had really good experience with it across many of the NICUs across the country. But again, it's that positioning of that reinfusion port is very critical. I remember many nights as a fellow, we'd sit there at the patient's bedside and you kind of hold their head and you move their head to one side a little bit. Well, my flow's got a little bit better. My sat's got a little bit better. No, now I need to pull it back this way. And so you're kind of constantly maneuvering their head to get the reinfusion port in the right spot. That's probably the biggest thing. Watching it on your chest x-rays every day. I've become a big fan of echoes to check cannula position frequently. The problems with the bicaval cannulas was right atrial perforation. They're great cannulas in older kids, I think, but in babies, the plastic's a little stiffer, they're reinforced. And in a baby, if it moves even a millimeter or two, it can punch through the right atrial appendage, or it can punch through just, the RA wall, which is never a good thing. And so I think paying close attention to where your cannula is, and really paying close attention to the location of your cannula, the SATs, and your neck position, to be honest. I mean, there's things to be careful of with neck position also. You obviously don't want to crank a kid's head all the way over to one side and have it sit there for days, because then you're going to get muscle injury and induced torticollis and things like that. Really, cannula position are the top three things with VV ECMO.
That's right. One quick follow-up question. In neonates, do you have any other options for VV other than dual lumen IJs?
Ooh, it depends on who you ask. That having been said, I have seen babies done with dual site cannulation for VV. The problem is getting adequate flows, I think, is going to be the biggest issue. That femoral vein would be the second site that we would typically go to. You'd put one in the neck and the other one in the femoral vein. That vein's very, very small in babies. If you think about the diameter of your aorta in a baby, it's that of a finger at most. And then once you get down to smaller vessels, specifically in the venous side, they get really tight. You could probably thread a 6 French in there if you had a surgeon that was bold enough. But from what I have heard people who have done it is you have problems getting flows. So yes, you can do it. It's certainly not optimal. And in those situations, I think a close discussion with your surgeon, your interventional radiologist, to see if you have to go that route, what's the best option that they have. I have read some case reports of some surgeons will sew a graft in onto the kind of a reinforced graft onto the vein, so their cannula is not actually sitting in the vein. But I would strongly discourage femoral cannulation.
Dr. Daniel, every time one of our first-year fellows or myself is having a hard time with a fem line in an infant, I say, the veins are small. It feels like a PIV. The veins are so small.
It's absolutely the tiniest thing ever.
We are intimately familiar.
Yes.
Yes.
We've mentioned double lumen cannulas already several times, and this might be a good time to maybe think about maybe a learner who doesn't have as much experience at the bedside with VV ECMO. How exactly do dual lumen cannulas work? What are their benefits? What are their risks?
The dual lumen cannula is really kind of an ingenious design. So basically you have drainage and infusion ports, and basically it's 2 cannulas in one is kind of how I like to think about it. You have one part of it that's a drainage side of the cannula, where you're going to pull blood out of the right atrium, out of your SVC, and that is going to travel through the cannula, out to the tubing, up to the oxygenator, get oxygenated, and then come back to the patient in the same cannula. So the second lumen of that cannula is going to be your arterial return port. And so that's where your oxygenated blood comes in, and it's going to come in and basically flow out of an infusion port. And so the way the cannulas is designed is you kind of get drainage and infusion in one cannula. I think a 13 French is the smallest one that we have right now on the market with the Crescent. And so you basically have 2 lumens within that one cannula that allow you to drain and reinfuse all on the venous side, which is great because it's one cannula in one vessel. The downsides of VV ECMO is you're only supporting the pulmonary system. You're not supporting the cardiac system at all. And so you really have to have a heart that functions well. Mm-hmm. The biggest advantage of VV ECMO, though, is that oxygen is a fabulous vasodilator. It's great. So you have highly oxygenated blood entering the pulmonary arterial system that's constricted for whatever reason, and that can lead to dilation of those pulmonary vessels. The other thing is you're not decompressing that right side at all. And so the right side is still struggling sometimes to work. I think the coolest form of ECMO in adult studies, I've read this, I haven't seen it done in adults, but they're starting to do, it's called V-PA ECMO, where basically they cannulate the venous side, but the return, the cannula goes in and the return is directly in the pulmonary artery. And so you bypass that right ventricle, you're able to rest that right ventricle, but still get the big vasodilatory effects of oxygen. I am obviously not an expert in VPA ECMO. It's more of an adult thing that I've read about now, but it's very cool.
Yeah. Look at you go, giving us new ideas for our ECMO series here.
There we go. I've mentioned the bicaval cannulas a couple times as compared to, say, the Crescent or the Origin cannulas. The bicaval cannulas, the design is pretty ingenious. So the reinfusion port kind of sits in between a distal and a proximal suction port, basically. So when you thread that catheter in, or that cannula in, sorry, it's designed so that part of it sits below the right atrium in the IVC, and another part kind of sits up in the SVC. And so you're going to have blood coming to the pump from the SVC and the IVC, running through the ECMO circuit, and then being reinfused in that middle reinfusion port. The benefit of that is you don't get something called recirculation. Mm-hmm. And what recirculation is where you have the blood that you are infusing into the patient getting sucked back up into the cannula. And so it's kind of just going around and around and around, and it's not going into the patient. And so I get worried about that anytime I see, a central venous sat and a peripheral sat that match. That's always concerning. That shouldn't happen. Even in VV ECMO, where you do have mixing there, you're not going to be able to rely on your central venous sat as much as you are in, say, a VA ECMO patient. But if they match, if your central venous sat and your peripheral sat match, something's going on. And that's typically a sign of recirculation. Also, you can look at the blood going in the infusion side and the suction side. If the color is the same, and one is not brighter than the other, then you're at risk for recirculation. There are several systems on the market that I won't go into that kind of can help you detect it, but those are the big ways I think clinically you can detect recirculation. You tend to see that more with the crescent or the origin cannula, where there's a suction port that sits basically on the cannula in the middle of the right atrium and a reinfusion port close to it. That was the big advantage of the bicaval cannulas. They're separate, you get less recirculation.
Mm-hmm. Something that is often underappreciated is the way that your lung expansion can sort of change the geometry of the space. How do you time your images and your confirmation with adjusting from the high vent settings to a more rest lung vent settings?
So it depends on which ventilator we're on. So if we're on a conventional ventilator with high pressure control or high APRV settings versus an oscillator, it's slightly different, but the concept is the same. So there is really no data to describe this process that we do. However, technically, people do know that as the lungs are very inflated, the intrathoracic pressure is very high, the space in there is bigger, and so the cannula will rest higher. Once the lungs deflate, that intrathoracic space becomes a little smaller, and that cannula will drop down. So depending on the size of your patient, those small changes could be a 0.5 centimeter, 1 centimeter, 1 to 2 centimeters that your lungs inflate or deflate. And that can absolutely change where that reinfusion port is sitting and how the jet is going towards the tricuspid valve. So if your cannula drops down 2 centimeters, your reinfusion port may be bouncing around the bottom of the right atrium. If your lungs are very inflated, then it may raise up to the top of the right atrium and be bouncing around the top of the right atrium. So it's really important to think about where do I want this cannula to be and how do I want my lungs to be? So generally speaking, we get onto VV, we want to rest the lungs, right? People talk about that all the time. What does rest even mean? But I try to get as close to what I think my rest settings are going to be in the OR or immediately during cannulation. My approach to rest settings is that I have to admit I generally fall into the philosophy of permissive atelectasis on ECMO. And so there's really probably two philosophies. So one is that you do permissive atelectasis, meaning whatever part of the lung has collapsed, you allow it to stay collapsed. And if other parts of the lung want to collapse on low to modest ventilator settings, then you allow that. The other philosophy is that you try to maintain as much of an open lung strategy as possible. But when I talk about my view of rest settings, I fall into that category of believing in permissive atelectasis.
You've taken a stand.
Yes, I have. And all my partners and friends at work know that. So, it's a good point of conversation. If we're on very high pressure control or APRV settings, as soon as I hear the specialist say on ECMO, I'm over by the ventilator with the anesthesiologist or the RT and we're turning it down. So I'm going to turn it down very slowly to get to what I'm going to consider rest settings for that patient. And so rest settings are different for every patient, in my opinion. Before I get back there, I usually have an idea of what I think those rest settings should be. And so I hear them say on ECMO and I start turning the vent down towards rest settings so that hopefully during or by the end of the echo, I'm on rest settings. And while the lungs will continue to deflate over that first 6, 12, 24 hours, they hopefully are a little bit closer to where they're going to be ultimately in the OR, because as we said, every tiny little centimeter or less than centimeter change may really change the oxygenation status of the patient. Getting as close to where we think that reinfusion port should be in the OR or at the time of cannulation, I think is really valuable for the patient going forward. So if I'm on the oscillator, then I will turn the oscillator down to low settings and convert over to the conventional ventilator during the echo if the patient's tolerating that. Again, for the same reason, we're on high mean airway pressure on the oscillator, and if I can get them over to conventional ventilator on what I hope it to be their rest settings, then that cannula will be closer to where the optimal place is at the time of placement.
I love visualizing the cardiopulmonary interactions just right in front of us there as we're cannulating. I mean, that's a great example. Neonates, what does it look like for you?
The surgeons do a great job of kind of estimating where it's supposed to go based on the baby's side. Oftentimes when the cannula is in the package, they lay it on top of the baby and kind of like, okay, we're going to go in at this position and then thread it to this mark on the cannula. And we have an idea of where it's supposed to go. So I think one of the things that's really the best option is to have a cardiologist there in the cannulation with you. And so that has been the most helpful for us. Once we're getting ready to go onto ECMO, we want to make sure the cannula is in good position. We call the cardiologist. They come up with their sonographer. We go on ECMO. We're watching, as soon as we go on, we're watching our indicators. We're watching our P inlet pressures and, return pressures to make sure that we're not having an excessively negative suction pressure or we're not having an excessively positive return pressure that could indicate there's an obstruction or the cannula's banged up against the arterial wall and you're having flow issues. But then really once the echo probe gets on the heart, really color Doppler on your echo to tell you where that infusion jet is going to go is the best way to do it. And it's really cool to see it also because you're watching it and you say, oh, well, here's the jet. It's not quite at the tricuspid valve. Try pulling it back this amount. And so the surgeon pulls it back a little bit. And then you're like, oh, there it is. It's right in the right spot. So that's probably the best way that I like to do it.
This might be a good time to just go ahead and flesh out what exactly is rest settings. Because if our goal is to be really close to that in the OR, let's go ahead and describe what that is for your practice and what you try to get to in the OR versus in the ICU later.
Yes. This is a very, I don't know what the right word to say. It's not emotional. It's not volatile. But
controversial.
People have a lot of feelings about what rest settings are. But if we think about the big picture, ECMO is meant to avoid ventilator-induced lung injury. So when we get on flow, we want to turn the vent down. We should be able to use the ECMO circuit to oxygenate the patient well enough and ventilate, meaning sweep the patient down well enough to support the patient's metabolic needs. So we don't need their saturations to be in the 90s or 100. And in fact, if they are upon cannulation, I wonder, did I cannulate too early? Because their lungs are actually contributing here. But it's very common for them to be in the 70s and 80s upon cannulation. And if that's where I'm sitting, I'm pretty happy about it. And so since the circuit is doing the work, I turn the ventilator down. And again, what does that mean? I don't think there are any set lung rest settings. But commonly, people talk about the 10-10-10 philosophy. And so, have you guys heard of that?
Oh, yes.
Yes. And so, where did that even come from? So, I think that came from the Caesar trial, which was an adult trial for ECMO and ventilator settings. That was kind of a head-to-head comparison. And it was one of the quintessential ECMO trials that people commonly refer to. And so, I think this is where the 10-10-10 philosophy came from. Again, that's in adults, right? We're talking about pediatric patients here. So, first of all, we know that maybe it doesn't apply linearly across the spectrum to all our pediatric patients. So if you look in the Red Book and it talks about what is rest settings, it also admits that there's no set idea of what rest settings should be, but generally speaking, it says we should maintain a PIP or peak inspiratory pressure less than 25, a PEEP anywhere from 5 to 15, so a big range, rate of 10 to 20, and an FiO2 less than 50%. So I think this is at least a starting place to think about what your rest settings are to be somewhere in that range. And so maybe your younger patient has a higher rate and your adolescent patient has a lower rate. I usually use a PEEP between 8 and 10 depending upon the patient and why I'm on. But generally speaking, my personal goals are to eventually evaluate every patient to wake up, extubate, and walk around. So what are the lowest settings I can start with so that I can do that over the next several couple days to weeks?
Would be interested in hearing your take as well. Do you think you have neonatal points that you think are going to be very different?
So I personally have become a big fan of lung rest extubation for respiratory kids. I think it does several things. First of all, it prevents that tendency that we all have when we start to see the lungs clear just a tiny little bit. It's like, oh, the lungs are clearing. And what does everybody do? They start cranking up the vent settings to try and open those lungs. A lot of that goes back to when ECMO was new. ECMO was high risk of bleeding, and the goal was use ECMO to get through that acute process and get off ECMO as fast as you can, regardless. I think we've learned over time that if we take our time a little bit, we can have better long-term outcomes, and we don't necessarily need to push people off ECMO before they're ready. I've really become more of a let's let the lungs rest and heal on their own rather than try and pop them open. So the reason I like extubation is for a couple things. Number one, when we looked at our patient population, babies here in particular, when you take that endotracheal tube out, the amount of neurosedation you have to use goes way down. So giving kids less morphine, less Versed, a good thing. We know that the less neurosedatives you have, the better your long-term brain development. The other thing that is really fun, and I think is a great way to help rehab babies on ECMO, is you can bottle feed them. Oh. The way to exercise a baby is to feed it and have it interact with its surroundings. And so if you're intubated, you can obviously use an NG tube and use it, do enteral feeds that way. But I think resting those lungs, decreasing your neurosedative burden, and working on bottle feeding for some of these kids is a great strategy to help them be a normal newborn while they're on ECMO.
So out of respect to the way that the mean airway pressure changes your cannula position, in the OR, you hear on pump, the Cards fellow's on their way, you drop to your initial rest settings, understanding that you'll titrate them. I imagine that the RV is going to change significantly between first cannulating to experiencing normoxemia, maybe decreasing your PVR. How do you monitor that over the first couple days?
As we talked about, the echo and possibly fluoro are used for placement of the cannula. Over the next coming days, and specifically the very first thing, day one after cannulation, I will always echo to look at where my cannula is. The first few days will see the most change probably in your inflation and deflation. And then I'll also point out here that the volume status of the patient is going to change the placement of that cannula. And that is frequently in flux those first couple of days as well. So when we talk about inflation and deflation, as I said, we try to get to low vent settings early, but over the course of that first 6 to 12, maybe 24 hours, we're still going to see some deflation. So I will echo first thing in the morning, either the next day or if the cannulation happened at night, just to see where that cannula is sitting and if we've had any change in being higher or lower and where that reinfusion port is oriented. And it's nice to know that as you go through the day, as opposed to finding out later when your patient acutely desaturates that your cannula is malpositioned. So I like to do that first thing in the morning and just have an idea of where I'm at day one. I do the same thing day 2, day 3, day 4, just depending upon how much adjustment in our deflation we've had, how much change in volume status, meaning did the patient diurese a bunch, and that is also when I'll start to monitor what's going on with the RV.
Tell us more about that.
The RV is a finicky thing, and I think there's more interest in monitoring the RV through time, and there's actually an RV protection network, and they're studying what's going on with the RV. And so I echo that every day. It's under so much strain, right, guys? So you've got these lungs, which I commonly refer to as bricks or concrete, causing huge afterload to the RV. And then we've got this giant jet of blood flowing into the right atrium and through the RV. And so how is the right side handling all of that strain? And it's really important to monitor that because, as we said at the top, cardiac failure and VV ECMO can be incompatible. Mm-hmm. So watching the RV for its health, I think, is very important. So it may not be obvious that things are changing with your RV and your right side of your heart right away. But it is helpful to then have serial sequential echoes over those first few days. And if you have a long run over those weeks, and really doing it at least weekly, in my opinion, to monitor for change. And sometimes it's not obvious. And so I'll have the cardiologist, pulmonary hypertension specialist specifically go back and put those in series and look at the first echo, where we are now, and see if we can see any change that's more obvious over that course of time. Because sometimes just the day-to-day changes aren't that obvious. And then additionally, I'll augment that with monitoring my NT-proBNP, or sometimes people have the BNP, but kind of looking at, health of the RV with those two fairly easy to obtain markers, I think is really valuable. And if I start to see changes in the right side early on, I am quick to add in milrinone to help relax the right side of the heart, relax my PVR as best as I can, and monitor on milrinone from there and see if that helps either slow down, stop progression of the RV, or even sometimes reverse it. That is what I'm looking for when I am echoing every day in addition to cannula placement.
Fantastic.
I love this really patient-focused deep dive in the cardiopulmonary interactions and how things change over those first few days of ECMO. Certainly is a wealth of knowledge for trainees to learn. So you have that neonate in your ICU on VV ECMO. Tell us about your general strategies for monitoring that patient.
The first thing is to make sure that you've documented just well the distance the cannula is in, where the cannula is on the neck, where it's sewn in. Some centers will actually mark on the skin where the insertion site is so they can tell whether it's migrated in or out a little bit. Daily chest x-rays, absolutely a must at minimum. And I think echoes are a great way to do it. It's fairly labor intensive though. And so my general thoughts on this is if you have a baby whose fluid status isn't changing a whole lot, puffing up or shrinking is going to cause your cannula to move in or out. And so I think if you're generally stable and in an even fluid balance, and you're not having flow issues, so you're not getting cutting out, you're not having excessive negative returns or things like that, if suction into the pump, then I think you're probably okay with a daily chest x-ray. I think at least an echo every other day, at minimum is probably good. With the real estate being so tiny, keeping a close eye on where that cannula is with an echo is very important.
Oh, yeah. And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.